So my objectives for today is I'm going to go through the updates of recommendations on guidelines on how to use vaccination in our patient population. So patients with rheumatic diseases, especially in the view of our biologics and new targets. So the flow of the talk will be, I'm going to revise some history with you. We're going to go over a little bit of basics and a little bit of concepts. And then most of the time we'll be revising some recommendations. And at the end, I'm going just to touch upon some controversies. So we all know, and we all know that the vaccination is actually considered as one of the most important and successful public health stories in the last decades. It's not only preventing diseases and illnesses, but it actually helps and aids into the development of education and economy of any country. The story, we have like multiple stories, but I just picked up the polio. So it depends really on how old are you. Probably what you know about polio differs from one generation to another. So this was a highly infectious disease in the early 1900s, and it leads to paralyzation of hundreds of thousands of people per year. Now, if you look at this graph, this is from the United States, and then you can look at this steep of reduction of cases that happens somewhere around 1955, and this was the time of the advancement of the polio vaccine. And since then, the number of new cases and the number of mortalities have went dramatically down. The story was a little bit different in Africa. So as you can see, by the late 1980s and early 1990s, we still have a lot of cases. And this actually have promoted the work of the WHO, the initiatives of WHO, and the mass leaders of the continent of Africa to kick polio out till they were actually declared as a polio-free continent. Now, this story has been replicated into multiple infections. So if you're talking smallpox, if you're talking measles, and then it tells you how much this intervention can be helpful for the mass and the general population. So just a little bit of basics. I know that this is the last day and this is the last session, so you don't need this in details. But the way that vaccine works is actually mimicking an infection, and then it actually initiates the immune response. So basically, you're taking the particles, the small particles from a killed or live attenuated vaccine, and then you just introduce it to the bloodstream. Then it will get recognized by specific immune cells, like the macrophages, TMB cells, and it engulfs it and express it on its surface by using the MHC receptor. T cells will be able to recognize the foreign antigen at this point, and once it gets activated, a proliferation of cytotoxic T cells, suppressor T cells, and helper T cells will happen, and then the hemagglutinin receptor on the T cell, on the helper T cell, would play an important role in antibody generation and memory B cell activation. The story is a little bit different in the B cells, as it doesn't require the MHC receptor to recognize the foreign antibody, so it engulfs it directly and then express it. And once the combination or the interaction, between the activated T helper cell and the B cell happens, lymphokines will be secreted. Now, the lymphokines will play an important role in the proliferation of plasma cells, which are going to produce antibodies against this foreign antigen, and the memory B cell that's going to help in the future immune response. Now, it's really important that we agree upon some definitions, so we're talking on the same page. So if you look at this table, the most important things is, like when you say a patient is immunosuppressed or the patient has a rheumatic disease, what do we mean by that? And then again, obviously the classic questions about the live and non-live vaccines. So as you can see, the list is very extensive. All of these medications are considered as immunosuppressive, but for the sake of memorizing them, we'll go with the non-immunosuppressive. So hydroxychloroquine is not an immunosuppressive, neither sulfasalazine, colchicine, apremilast, denosumab, and or IVIG. So these are the non-immunosuppressive. Otherwise, everything else is immunosuppressive that we use. Again, this is just a reminder, when we say live attenuated vaccine. These are the ones. And I just want to keep, to bring your attention that when we talk in influenza, it can be alive, that if you use it intranasal, as well as the varicella. But these two vaccines, we have the alternatives of the non-live vaccines. Now, what makes us say that vaccines works? I think this is what we define by efficacy. Now, efficacy is the capacity of vaccination to prevent infections. And how can you measure that? It will be translated into lower rate of hospital admissions, lower rate of infections, and lower rate of extensive or invasive infections. So this is how we know that vaccines works. The other way is by immunogenicity. Now, the immunogenicity is the capacity of vaccine to induce humoral and or cellular immune responses. So these two measures will give you an impression on if your vaccine actually works or not. So in rheumatology, it's been extensively shown that infectious disease is one of our biggest enemy. People who has rheumatic disease, they are at higher risk of developing morbidities and mortalities if they get an infection. So now the EULAR and the ACR, these are the two most recent guidelines and recommendations. I'm going to use a little bit of both just to elaborate some points. Now again, the strength of recommendations would depend primarily on the efficacy. So if they have data suggestive that the infections rate is getting less and less, this is the primary evidence. And the surrogate will be the immunogenicity. So if you actually have both of them, that's a strong evidence. If you have one of them, like for example, the immunogenicity, you don't have enough evidence of efficacy, the evidence will go lower. And hence, they will use a conditional recommendation. I will start with some overarching principles. For you who goes over the guidelines and recommendation would see it in the EULAR recommendation. And they started with the first one, which is that the vaccination status and the indication and further vaccination is actually the responsibility of the rheumatology team. The second one would be the individualized, the shared decision-making process that's, as we always recommended for any of our diseases, again, should be taken by the rheumatology team. Now, I think Dr. Arfaj, because he has mentioned this at the beginning, I think this is one of the most important points. People who should take care should be defined. It shouldn't be left out in the open. So we don't know if the public health will do it or if the family medicine physician would do it or whatever. I think this is our responsibility that we should take care of to fill up the gaps that might happen in the whatever health system. Now, if the health system in your institution is good and they take care of this, then this is fine. Otherwise, if we don't have it, I think the rheumatologist should take care of it. Okay, so we'll go to more specific indication. If we go for influenza vaccines, now it has been shown extensively that in rheumatoid arthritis, if you have rheumatoid arthritis, the incidence of influenza would be higher. Even if you're taking the medications, if you're taking biologic DMARDs or DMARDs, the percentage is not statistically different, but it's a little bit higher numerically. But you're going to have a higher rate of having complications due to the influenza vaccine, due to the influenza infection. Lupus, in this trial, actually it showed that the actual comparison between vaccinated and non-vaccinated lupus patients and how do they perform better in terms of extensive and emergency visit and worse outcomes in regard to influenza. So the guideline or the recommendation by the ACR, they stated as for patients who aged 18 or more, they should receive high dose vaccine or adjuvated vaccine. I actually did not like the vocabulary, so I took the advantage to write my own. All patients with rheumatic diseases should receive influenza vaccine. Now, I put a little star because obviously it's an individualized decision. But actually, any type of vaccine will be better than giving no vaccines. So ideally speaking, the evidence of high dose influenza vaccine would be better for immunogenicity. But they're saying that even if you have any type in your pharmacy, you should do it, give it right away. And if you have it, it's better to give it today than delay it. So I think this is really important to grasp because the delay in the process can happen in many steps. But I think we should give it right away whenever you find out that the patient did not have their seasonal influenza. Now, I know that some of you will ask, well, if the patient is having an active disease, what should we do? But I'm going to answer you later. What about pneumococcal vaccination? Again, it shows that if you are older and having an autoimmune or rheumatic diseases, you tend to have a more invasive and you tend to have more infections by pneumococcal organisms. Now, the WHO have stated that all individuals more than 65, they should receive it. So this is not a brainer. Anyone who's older than 65, they should receive it. Now, how about those who are adults and they are less than 65? And they are our patients who are taking our immunosuppressives. The recommendation would suggest that PCV 13 or 15 should be followed by the polysaccharide pneumococcal vaccine. So again, all patients with rheumatic disease and immunosuppressed, they should receive the pneumococcal vaccine. Obviously, you're going to give these two vaccines, and then it will be valid for 5 years. There is a newer one, the PCV 20, but I don't think if it's available yet. Zoster, again, the question was a little bit complicated. Are they only for the older people, or can we use it for younger patients? The incidence of zoster, it increases over the years, and obviously it increases more in older population. And many diseases increases the risk of zoster, and as you can see, lupus is significantly increasing the risk of incidence, as well as other rheumatic diseases. So the suggestion was that any patient who aged more than 18, they should receive, and again, this is a conditional recommendation, they should receive the 2 doses spaced at least 4 weeks, ideally speaking from 2 to 6 months. Yani, if you take the first shot today, the second shot should be from 2 to 4 months. You have to know what do you have in your hospital. So obviously we have the non-live and live vaccines, the non-live, which is the Shingrix, the trade name, or Viravax, which is the live. So most of the healthcare centers by Ministry of Health, they have the killed vaccine, which is the one that makes your life easier. The live attenuated, there is a little bit of specification that I'm going to show it to you later on. So you should know what do you have in your hospital. Other important vaccines, which is the HPV. Now, again, this vaccine has been endorsed, and a lot of awareness campaigns have been started and initiated to try to eradicate the HPV. So any patient who is from 26, any female patients from 26 till 45, they should receive the vaccine, having that they did not receive it in the past. So even the HPV, there is a national campaign trying to increase the awareness of the HPV. In terms of other vaccinations like the MMR, the tetanus, the hepatitis, it really depends on if the patient has the risk factors or if there is a national updates in that regard. I will end up by some controversies and frequently asked questions. So just a reminder, this is the inactivated and the live attenuated vaccines. So the very first question would be, should we delay the vaccination till the disease is in remission? I think this is a very legitimate question that usually rheumatologists would ask it even before their patients. And this is one of the things that I found 2 different opinions between guidelines. So the EULAR was suggesting that during quiescent disease, it will be preferable to give the vaccine, preferable. But for the ACR, they suggested that giving a non-live attenuated vaccine regardless of their disease activity. And they supported their say based on a specific, on evidence that's suggesting that even if you give the vaccine for someone who has an active disease, that would not really interfere. That the disease will not get active, the efficacy would not be it would not happen. I mean, it's okay to give it if the disease is in quiescent status, but if that doesn't happen, we should not delay the vaccine for a long time. So should we stop the immunosuppression? Again, the main concerns is that if you take giving an immunosuppression while you're giving the vaccine, either the disease will get active or the vaccine, you might induce the infection that you're trying to prevent from. But the story was the methotrexate story. As you remember, it's been entertained for the past 10 years that if you hold the methotrexate, the immunogenicity would improve. Although actually the EULAR, the 2019, they did not suggest this. They've just mentioned it, but they did not suggest it. But I think the evidence is clear that whenever the case, whenever the situation allows, you should try to stop it for 2 weeks after the vaccination. And this has been elaborated as a single recommendation. Now, how about the other medications? Should we stop them or not? So methotrexate we've talked about. But in other non-live vaccines, other than the influenza vaccine, you should give it freely. For rituximab, you can give it while the patient is taking rituximab, you can give the influenza vaccine. However, for the other non-live attenuated vaccines, you should try to schedule it. And the schedule will be holding rituximab at least 2 weeks after the vaccination if the cycle comes. Other immunosuppressive, you're able to give the vaccines, either the influenza vaccine or the non-live attenuated vaccines. So, and the main reason is for the efficacy of the vaccine. Holding it, it will increase the efficacy of the vaccine, and that was stated with the methotrexate and influenza. Now, how about the glucocorticoids? Are the glucocorticoids is one of the concerns. Again, they've separated them based on the dose and the vaccine. So there is the influenza vaccine and the other non-live attenuated vaccines. Just to give you a hint, so 20 milligrams, so more than 20 milligrams, and if you're trying to give other non-live attenuated vaccines, defer it. You can push it at another time. And then, actually, this might correlate with the disease activity. So 20 milligrams is the cutoff limit. The story is different for live attenuated vaccines: measles, mumps, polio, typhoid, varicella zoster, and yellow fever. The ones in the varicella, obviously, we have the alternatives. Now, if you look at this list, luckily, alhamdulillah, we don't use it a lot, especially if we have the zoster, the alternative zoster, the killed one. So we are not facing this situation from day to day, but in case if you face it, this is the recommended schedule or table, suggesting that you have to hold the medications before, hold the medications after. It differs really from what medication you are using, but I don't think that this is our day-to-day situation, but in case if you have to do it, this is the way how to do it. Infants, because I think it's your responsibility to tell, usually the pediatrician or the family physician would not pay much attention. Just to remind you that the infants, for a mother who is taking anti-rheumatic drugs, we used to have a little bit of concern, especially with the BCG. Now remember, back in the days, the BCG was on day 1. But if you look at the booklet nowadays, they actually moved it till after 6 months. So inshallah, we're doing okay. But rotavirus is different. So rotavirus is a live vaccine, and usually they give it at 2 months and 4 months of age for the infant. So if the patient is on TNF inhibitor, they can take the rotavirus. But if they are on rituximab for a reason or another, you should delay the rotavirus after 6 months. Now, the interesting thing is, despite that, the burden of infections attributed to rheumatic diseases is high. And we've shown you that there are an efficacy for vaccination of these patients. So these facts has been established extensively in the past. However, we still have lower vaccination rate if you compare our patient to general population. Like, for example, the pneumococcal vaccine was 17.2%. Influenza vaccine was 25.3%, and these percentage, there has a big disparities between countries. So if you are in Japan, it's not like if you are in Morocco. So that was a very interesting thought, and if you sit and try to think, why is that? You'll find that there are some barriers. I should say that the biggest one is low awareness, either from the rheumatologist or the physician, and or from the patients, obviously. The patients have an additional psychosocial factors, the media and the other concepts that might affect their decision. A deep counseling. So I have to convince you in order for you to convince your patients. A deep counseling should do most of the job, but I should say that we would forget. I mean, from day to day, if you are in your clinic and then you're seeing your 15 or 18 patients and then they go, probably you will forget. So it's very good that you actually use a checklist or a reminder for you to think, to remind your patients. So this is something from room info, and I'm sure that any hospital can do, can include it in the electronic medical records or something else. Hopefully I'm on time. I know that this is the last session, so there is no way that we take longer than our designated time. So I hope that I convince you that vaccination is crucial to our patients. And keep in your mind that recommendations are temporary and dynamic. So they are changing because you might have a new infection and there might be an evidence and newer evidences. The effort to increase vaccination will actually impact your patients' lives and health, and it will improve the quality of care in your institution. And lastly, don't forget the influenza, pneumococcal, and zoster vaccines. Thank you.